first began SHARP I lectured for SHARP in 2013, and then became a mentor, and then eventually got to now co-direct with Jonathan since I think about 2018. So SHARP is a 10-week training program here at DPH in collaboration with UCSF. Fundamentally, it's sort of, in short, living the life as a researcher for 10 weeks. They come here, they read, they see, they engage with mentors, networks, peers, community-based organizations, clinical shadowing, and the through line is development of their research projects, which they're going to be presenting on today. And our goal is to really help develop the next generation of folks who are going to be pursuing HIV, substance use, public health, and clinical careers. See here. So SHARP has been funded through the National Institutes of Health. First, the National Institute of Mental Health. That was the first 5 years. The second 5 years was the National Institute on Drug Abuse. And then we continued and we got successfully renewed a few years back. So now we're in the 13th annual year. In this short 10-year period, and you can add the numbers to where we are in 2026, we get on average at minimum 100, sometimes as high as 170 plus applications for 6 slots each summer. 100% all of the scholars who have come through the program have completed it successfully. Many more co-authored and first authored publications from our trainees. It's about half going on, half have matriculated into grad school or medical school, but even more go into clinical research roles, both here at DPH, UCSF, and other programs around the country. So it is a great workforce development program that we are really, really proud of. And I think it speaks to just how brilliant these 6 folks are. Of all the hundreds of applications we got, you're going to see a really great group of 6 today. And so with that, I want to also thank all of our mentors, Natasha, Philip, Nadra, Oliver, Grace, and Michelle and Amy, who helped with the photo voice. Given the mechanism, we can't fund, we are not allowed to fund mentors for their time, but we want to say a big gratitude of thanks for all of the hours you've spent with the scholars, the emails, the text messages, the meetings in person, the lunches, the socials. It really means a lot to both us as the group and to them. And so big round of applause to the mentors. And with that, I will pass it over to Lauren.
So I'd love to invite Dr. Susan Phillip up. Dr. Susan Phillip is our health officer for the City and County of San Francisco and the Director of Population Health Division of the San Francisco Department of Public Health. As health officer, her focus is on supporting all communities to have equal opportunities for good health. Let me bring up Dr. Phillip.
Thank you so much, Lauren, and good morning, everyone. I am so happy to be here with you all, and I'm even happier, thanks to Nika, I'm able to stay the whole time. She cleared my calendar, so she's the real hero to me for letting me be here. I want to start by welcoming our SHARP scholars, their families and friends, mentors, our faculty partners from UCSF, community organizations, and colleagues from across the San Francisco Department of Public Health, and really everyone who's joined us for this year's SHARP Symposium. Today is one of my favorite kinds of public health events because it reminds us of why we do this work day in and day out. And on a personal note, it reminds me of my start in public health. Before I held any type of public health job, before I had a public health career, I was a research trainee at Bridge HIV under the mentorship of Dr. Susan Buchbinder, and I learned just as you have this summer. SFDPH continues to be a special place because of the proximity and connection between cutting-edge science and groundbreaking public health implementation led by community wisdom. To our 2026 SHARP scholars, congratulations. Over the past 10 weeks, as we've heard, you've immersed yourself in HIV research, substance use health, epidemiology, implementation science, health equity, and community-based public health practice. You've worked alongside researchers, learned from experienced mentors, explored public health challenges, from multiple perspectives, including, very importantly, your own, and contributed to projects that address real issues facing our communities every day. It's an incredible accomplishment, and every one of you should be proud of what you have achieved. So earlier this month, many of you have heard Lauren Dangerfield and the SHARP team share the history of this remarkable program, just as Dr. Saceda did, very succinctly just now. And you've learned of the more than 1,400 students who have applied since SHARP began in 2012, the 77 who have completed the program, the publications, the graduate school acceptances, and the alumni of this great program that have continued serving in research and in public health, including many who have returned right here to work with us at the San Francisco Department of Public Health. These are remarkable accomplishments, and they represent opportunities that have the potential to change lives. They represent mentors who've opened their doors and shared their expertise, as we have heard, and they represent students who've discovered careers they may never have imagined for themselves. They represent something that is essential to the future of public health, our workforce. Across the country, health departments are asking an important question: who's going to lead public health in the years to come? It's a challenging time, as we all know, for public health, and more than ever, we really want to make sure that we are attracting and retaining really bright, committed people who are going to bring their expertise, their lived experience, to solving really deep problems that we have in public health across the country. That workforce issue and that change that we want to see doesn't happen just when someone accepts their first job. It begins earlier, when students are given meaningful opportunities to contribute, when they are trusted with real projects, and when they're challenged to think critically, and when they work alongside professionals who believe in them and work with them, and when they begin to see themselves not as just as students, but as future public health leaders. And this is what SHARP provides. What makes SHARP so special is that it is much more than just a summer internship. You, our 2026 SHARP scholars, haven't simply observed public health in action, you have experienced it. Throughout the summer, you've worked alongside researchers and epidemiologists, tackling some of our most pressing public health challenges. You've explored HIV prevention and treatment, substance use health, epidemiology, implementation science, and community engagement. You've learned how surveillance data helps us understand trends and guide decision-making. And you visited community organizations, engaged with public health leaders, and gained insight into the different disciplines work together to improve public health across San Francisco. And most importantly, you've learned something that all of us as public health professionals eventually discover: our work only matters when it improves people's lives. We have strong lessons in this from HIV, and of course, San Francisco has long been recognized as a world leader in the response to HIV. The formula for that, of course, has always been science coupled with community leadership and public health program and policies that are aimed to ensure that everyone had access to prevention, treatment, and compassionate care. Those same principles continue to guide our work today at the San Francisco Department of Public Health, not only in HIV, but in substance use health, infectious disease prevention, chronic disease prevention, and in every other area of our work. I also want to pause, and as Dr. Saceda did, to recognize the mentors, supervisors, faculty, and staff who've invested in these scholars throughout the summer. Mentorship is one of the greatest gifts that can be offered. Every meeting a scholar is invited into, every project, every question that has been answered, every piece of thoughtful feedback, those moments shape careers, and they are so, so meaningful. I'd venture to say that all of us are standing here where we are today because someone took a chance on us early in our careers. Thank you, mentors, for investing your time, your expertise, and your encouragement to our 2026 SHARP scholars. And to the scholars, in just a few moments, we are going to hear presentations from each of you, and I am so excited for that. We're going to hear you discuss the research you've conducted, the questions you've explored, and the lessons you've learned throughout the summer. For all of us, as we listen today, I encourage us to look beyond the slides, listen for the curiosity, the confidence, the growth that has happened. And because today is more than the research projects. Clearly, those are critical, and again, I'm so excited to hear them. But it's about our future leaders and showcasing them. And to our scholars, your perspective matters so much. Your experiences as people, your lived experiences matter, your ideas matter, and the questions you ask today could become tomorrow's research studies, public health policies, or community programs that improve people's lives and strengthen our community. Before I conclude, I want to thank everyone who helped make today's symposium possible. Thank you to Dr. Jonathan Fuchs and Dr. John Saceda for their leadership and their vision. Thank you to the amazing Lauren Dangerfield for all the incredible work to make this program a reality, and your commitment to public health workforce of the future and to our sharp scholars. Thank you again to the mentors, faculty, community partners, family, and colleagues for believing in these scholars and supporting them throughout the summer. So today we celebrate you scholars, not only everything you've accomplished over the past 10 weeks, but the leaders you're becoming and that you are right now. Everyone in this room is here because we believe in you. We're excited to celebrate you. We know your potential. We believe in your future. And we believe in the future of our shared work of public health because you have chosen to be in it and you are part of it from now for forevermore, whatever you decide to do. Congratulations on an incredible summer. I look so forward to hearing from each of you during your presentations, and thank you all, and I'm looking forward, and let's all enjoy the symposium. Thank you.
Alrighty, thank you, Dr. Saceda. And thank you, Dr. Phillip, for sharing those words. Come on. Alrighty, so as Gabby gets her presentation ready, I will share a little bit about Gabby herself. Okay. Gabby is a third-year Filipino-American student at UC Berkeley studying public health and public policy on the pre-MD, JD, and PH track. She founded For Kind, a statewide nonprofit focused on advocacy for marginalized communities, and serves as a public health director at the Mumbai Health Center in San Francisco. She has worked as a California volunteer intern for the Office of the Governor, interned at the California Department of Public Health Gonorrhea Surveillance System, and is currently a development and external relations student worker at the Berkeley School of Public Health. She has conducted original research on holistic health for AAPI women survivors of sexual violence in Alameda County, and she inspires to work as a physician shaping global public health policy. I would also like to share that Gabby is definitely a go-getter. She is one student that was able to do the most informational interviews, even reaching out to Dr. Phillip herself at 24 in 10 weeks. So really just want to congratulate Gabby. Come on up.
Amazing. Good morning, everyone. How are we doing today? Good. Amazing. Thank you so much, Lauren, for that incredible introduction, to Dr. Phillip for such an amazing opening speech, and to everyone for being here to support our research. My name is Gabriela Torres, and I'm one of 6 SHARP scholars this summer. And my mentor is Dr. Michelle Nakfong, and for my project, I investigated Care, Connections, and Cash, a qualitative analysis of formerly incarcerated transgender women living with HIV from the Guaranteed Income Boost Pilot Program. So a little bit more about me. I'm a Filipino-American from Chino Hills, California, and a rising senior at UC Berkeley studying public health and public policy on the pre-MD, JD, MPH track. My dream career is to work as an infectious disease physician in local, regional, state, or national government, advocating for health policies affecting my communities. Now for a little bit of background. The latest data from the San Francisco Department of Public Health, HIV Epidemiology and Surveillance tell us that 15,400 residents were diagnosed with HIV in December of 2024. There was a 4.3% increase in new HIV cases from 2023 to 2024, and out of this, 6% of these cases identified as trans women. It is also important to note that these individuals had lower levels of viral suppression, which led to heightened vulnerability. Incarceration is also seen as a major disruption to retaining HIV care. In fact, 1 in 7 people living with HIV, or PLWH, experience incarceration annually. Additionally, those from that group that experience criminal legal involvement, or CLI, have 3 times higher HIV prevalence than the general population. Now, how do we address this issue for this specific demographic? Well, we can view guaranteed income, or GI, as an important intervention. It's a method of providing regular, unrestricted cash payments to supplement an individual's income. Now, why implement GI for incarcerated trans women? First, GI is seen to target people who have benefits that are still not enough to meet all basic needs. CDC's National HIV Behavioral Surveillance Study in 2024 found an association with longer duration of homelessness for incarcerated trans women, as well as lower forms of social support. Providing extra cash would allow this population to reduce competing priorities at reentry and create greater financial stability and autonomy. Cash transfer programs are seen to take different forms in different places. From Brazil's conditional program for women with AIDS to Florida's unconditional program for formerly incarcerated individuals, GI has served demographics with varying needs. However, there has not been one study that combines all identities of being a low-income individual living with HIV that has been formerly incarcerated. The idea of GI being unconditional has lowered the barriers for participants, as there is no requirement to qualify or restrictions of what to purchase with the money. Continuity of HIV care is a structural issue. Being able to implement GI programs for this demographic treats this issue as such, since incarceration has association with HIV-related infections among those in the jail system. By relieving the burden
Of competing priorities at reentry,
stabilizing finances, and increasing autonomy, people can take better control of their lives. This study focuses on an ongoing 3-arm pilot study of an unconditional cash transfer program called GI Boost, and is to aim to target low-income PLWH CLI that have been released from San Francisco County, or SFC jail. This leads me to my research question, which asks, what is the perceived impact of guaranteed income in supporting formerly incarcerated transgender women living with HIV to engage with HIV care? Looking at our GI Boost study timeline, we can see that the larger study started last year, with qualitative interviews taking place from January to March of this year. My study analyzed these baseline qualitative interviews of participants before they received the money to understand their current relationship with HIV care, financial experiences post-incarceration, and their plans to spend the cash. For my methodology, I studied 6 low-income adult trans women living with HIV released from SFC jail and analyzed their baseline in-depth interviews with topics ranging from social support to HIV care following release. I performed a qualitative secondary analysis for the study and used an existing codebook across all 6 interviews to apply a deductive coding process. I then used an inductive coding process to uncover emerging themes between and across quotes. I established inter-rater reliability by coding 2 transcripts simultaneously with my mentor to resolve discrepancies, then coded the remaining 4 on my own. Lastly, using Deduce, I applied a framework analysis by utilizing several matrices to track themes. From these interviews, 3 key themes emerged. 1, barriers to HIV care continuity. 2, how social support strengthens HIV care engagement. And 3, the perceived impact of GI for participants. Regarding barriers to HIV care continuity, transportation surfaced as a primary struggle for participants. Both of these women experienced anxiety riding the bus or being in public, which has contributed to their inability to attend appointments and labs. It should be noted that it is not the lack of transportation available, but the personal fear of presumed harassment, social scrutiny, and discrimination that may occur in public. Several participants not mentioned here have disclosed their preference of taking a more private transportation, such as a car, which would alleviate this barrier. Additionally, participants have experienced disrespect from service providers. On the left, a woman shared, quote, "The clinic really put me in a bad place. I felt disrespected." This tension is particularly striking within healthcare settings, where clinics are tasked to provide resources that simultaneously reproduce harm. requiring participants to fight for the basic respect that should be inherent to healthcare itself. To the right, we see a participant discontinue their medication because no one was there to provide consistent accountability and encouragement. These lived experiences imply that positive social support is necessary to sustain engagement in and adherence to care. Against these barriers, social support emerged as a critical counterforce to help participants navigate the healthcare system. By having relational and lived experience support alongside practical care navigation, participants were better equipped to overcome logistical barriers while feeling seen and understood in their experiences. Together, these forms of social support reduced the burdens participants had to carry all on their own. The quote on the left showcases the importance of lived experience as a form of expertise, lessening the distance between the In regards to practical care navigation, both participants revealed how easy it was to navigate and engage in care. The quote on the left acknowledges her case manager. Quote, "She does everything for me. If I have an appointment, she'll come and get me. She'll come and knock on my door, make sure I made it there, you know?" The quote on the right explains how her doctor would provide Ubers to and from their meetings to, quote, "show up for my care." Together, these stories suggest that effective support did not wait for participants to overcome barriers independently, but allowed for providers to extend their care beyond the clinic to navigate it too. Lastly, the theme of perceived impact of GI investigated how participants used extra cash to purchase beyond basic needs, while also viewing this program as a way to give back to their greater community. The participant on the left plans to use the cash to get a car because her electric skateboard broke. Several participants not mentioned here also had plans of getting a car for ease of attending appointments, which supports our finding that safe and private transportation is not only convenient but necessary to engage in care. The participant on the right wishes to get a dog for companionship, reflecting how unrestricted income can support quality of life and forms of well-being that are just as meaningful as basic needs. Lastly, I'd like to highlight how participants use GI Boost to give back to their communities. These quotes were particularly meaningful to me, and I invite you all to read along. On the left, a woman shared, "I always like to be part of things like this because I know it helps the future. Maybe people don't have to put up with the same BS that I had to put up with." And a woman on the right says, "I think that it's great that there's people out there that really do care for us. They're just not putting us on the back burner and leaving us out there to suffer, because we can't do everything on our own, you know? I'm just glad that I can be part of this study and help the next group of people." These experiences showcase how they are not just recipients to the resource, but contributors capable of shaping the conditions faced by those who come after them. They also underscore why qualitative research like this matters. It preserves lived experience as evidence, capturing forms of resilience that traditional health outcomes often fail to capture. With this, we can conclude that the perceived impact of GI was deemed beneficial for participants to engage in HIV care. When discussing social support, we can see how HIV care continuity is a shared responsibility between the provider and the patient. Relational support may also determine whether logistical support actually works. An Uber or referral may remove a practical barrier, but may determine whether someone feels comfortable accepting the assistance in the first place. Finally, GI can complement support services, but not fully replace it. Participants can determine what would improve their stability or quality of life, shifting autonomy and power from institutions to people themselves. This study had several limitations, with the first being the small and highly specific sample, making findings difficult to generalize with the broader population. Interviews were conducted at baseline, and experiences were self-reported, which may lead to recall or social desirability biases when reflecting on HIV care in and out of incarceration. And finally, demographics outside their age and ethnicity were not disclosed to preserve confidentiality. For implications, it's crucial to work closely with agencies to strengthen existing programs that implement transportation and appointment coordination strategies. I would also speculate that collaborating with and improving trainings for service and care providers would better improve the quality of interactions for this community. Finally, as almost all participants have heard about GI Boost because of a friend, leveraging these existing networks would make disbursement of health education and programs more accessible. Future studies should compare participant experiences after the program, compare these interviews with those of cisgender men, and examine the cost, sustainability, acceptability, and feasibility of GI fully in San Francisco. Whether these studies are qualitative or randomized control trials, the future of public health should not be measured by whether people can navigate our failing systems, but by whether those systems are transformed by those that had to withstand them. I would like to give my most sincere appreciation to my mentor, Dr. Michelle Nakbong, for guiding me through this journey and inspiring me to continue pursuing research, to the GI Boost study team and our funder, California HIV/AIDS Research Program, to Lauren, Dr. Fuchs, Dr. Saceda, for taking a chance on me to contribute to SFDPH, NIDA for investing in our success, my fellow Sharp scholars for making every 8 a.m. morning worth showing up for, and the participants of this work and their willingness to share their stories for a more equitable future. This experience has deepened and reaffirmed my passion for infectious disease epidemiology, specifically HIV/AIDS, and has motivated me to continue taking space in positions where representation can inspire others who look like me to navigate and see themselves in these fields too. Thank you so much. You can go ahead and scan my business card for more information, and I'm happy to take questions.
Thank you, Gabby. Great talk. So we
Thank
will
you.
have 1-2 questions. Yeah. So we have time for 1-2 questions for Gabby. Please don't be shy.
Frank.
Raise your hand over here.
My question was about the social support for the participants in the study, but because there was mentioning of the provider, the case manager, and the peer counselor. So I know that social support is important, but were they like part of a team, or were they separate, or did they like communicate with each other? Because I think right now there's a lot of like separation or silos. So I know that. So it's just like, yeah, just curious about if you know whether they coordinated together, or if they were like separate in the community.
Yeah, thank you so much, Ring, for that question. So a lot of these participants, again, were in existing networks within San Francisco and in the HIV network that is over here. And so these participants did know about the program and other resources because they would talk to each other. But specifically with those care providers, it was, some of them were kind of given through like this network of like, once they got out of jail, they were connected because of someone else. But again, all of these programs, organizations, agencies, a lot of them are through word of mouth or because other people knew about them beforehand. And so, yes, I would say like because of this, San Francisco is a very tight-knit community, and a lot of people really just know about these resources because of things. So I think like to your question, there may not be as many silos in San Francisco as in other areas, which has probably contributed to the strengthening of these relationships. So, yeah.
Thank you. Other question? Wait, time? Or I have a question, Gabby. How have you been thinking about, and maybe even in discussions with Michelle, about the sustainability critique that often GI programs get?
Yeah, that's a great question. Thank you, Dr. Saceda. I think for sustainability, obviously there is still the pilot program going on. We're actually expecting the program to end closer to next year because they are still in the midst of them receiving the cash. And so for my knowledge, I don't know a lot about, whatever programs are specifically going to be successful in San Francisco, but I would just say that because this is such a very niche population, it might be realistically a bit harder to convince policymakers and other stakeholders to really implement this in populations. I think it's also important to note that because every participant actually gets $6,000 for 9 months, and this is a lot of money, and a lot of people can find concern in, where is this funding really going? What is it actually being used for? And so because there's not many restrictions for this as well, people can have some concern. And so I think for sustainability, that is something that we'll have to research and just be able to review more, but that's the whole point of our pilot program, to ensure and see the feasibility of this and see how other people in the community also react. So yes, thank you.
Quick question.
Yeah.
Were all of the participants housed?
So actually, a lot of these participants, for eligibility, they either had to be low income or experience homelessness.
Okay.
All right, round of applause for Gabby.
Thank you so much.
Awesome. Thank you, Gabby. I will. And she was working as a student assistant at the Neisseria Reference Laboratory on doing gonorrhea research. Her interest is in STI epidemiology. Her interest grew after taking an epidemiology course through UW, and she is really interested also in working with the LGBTQ community. Please welcome up Olivia.
That's a good height. Okay. Great. Thank you, Gabby, for that amazing presentation about transgender women experiences with the Unconditional Cash Program and their care after jail. I really appreciated your insights. My name is Califia Oldham, and my talk is titled The Invisible Barrier, Internalized HIV Stigma, Depression, and Their Role in Care Engagement. My mentor this summer was Dr. Najalisha, a biostatistician working at UCSF. Bachelor of Science from the University of Washington in Public Health Global Health in 2025. I'm currently pursuing an MPH at UC Berkeley this fall in epidemiology and biostatistics. And outside of school and research, I love to do anything outdoors, including rock climbing, hiking, biking, camping, you name it. So my research project looked at internalized HIV stigma and how it may be associated with care engagement. Care engagement can be described as the active connection people have to their HIV providers and their care, which is crucial for positive health outcomes. Positive HIV health outcomes include having an undetectable viral load, maintaining a strong immune system, and living a longer life. A 2026 CDC report showed that amongst the 1.1 million people living with HIV in the United States in 2024, that 77% of people had received some HIV care, 56% were retained in care, and 69% had achieved viral suppression. These numbers show that there's still a lot of work that needs to be done to get people connected and engaged with their HIV care. Viral suppression is an important indicator of successful HIV treatment and care engagement, but it doesn't necessarily capture the full picture of what it means to be engaged in care. There are many factors that influence someone's care engagement, which include access to care, health literacy, transportation barriers, mental health conditions like depression and anxiety, and lastly, stigma. Recent data shows that 43% of people living with HIV have experienced some form of stigma, and about 1/3 of people living with HIV have experienced depression. Both of these factors have been associated with poor ART adherence, reduced self-image, worse mental health, and lower retention and care. But more importantly, they remain two of the most consistent barriers to HIV prevention and treatment, making them ongoing priorities for research and interventions. And despite stigma and depression being continuously researched, there is still a gap at understanding how these factors interact with one another and how they influence HIV care engagement to create successful interventions for people, especially populations that experience greater levels of stigma. My research project focuses on what is specifically called internalized HIV stigma, which is the acceptance of negative societal characterizations, labels, and thoughts about HIV and applying them to oneself. For example, someone living with HIV might see stereotypes in the media that people that have HIV are dirty or they're sexual, and they internalize these stereotypes and apply them to themselves. This is harmful because it can contribute to avoiding medical care, experiencing mental health issues, and having difficulty adhering to medications. Research has also shown that certain populations experience disproportionate amounts of stigma, including the Latinx community. This may be due to social and cultural factors, including the stigmatizing association that HIV is acquired by irresponsible behavior, as well as all the stigma surrounding homosexuality, multiple sexual partners, and drug use. Which all leads me to my research question of, does depression mediate the association between internalized HIV stigma and care engagement amongst Latinx people living with HIV in the United States? If you are unfamiliar with a mediation analysis, it is a useful tool of understanding how variables are connected in a causal pathway. Instead of looking at if stigma is associated with reduced care engagement, we examine whether depression may help explain this association. In other words, we are asking whether people who experience higher levels of internalized stigma also experience more depression, and whether that depression is then associated with lower care engagement. This type of analysis is useful when designing medical, educational, and social interventions because it can help identify specific risk factors. For example, if my analysis shows that depression is a significant mediator, it could suggest depression-specific interventions may be one potential way to improve care engagement amongst this specific population. So for my project, I got data from the CNICS National Dataset, which is a part of the CFAR network, or the Center of AIDS Research. CNICS acquires data at point of care from specific sites in the network, shown on the map to the right, which primarily include large academic medical centers. The data often includes demographic information, lab results, and patient-reported outcomes like surveys about care engagement, depression, their alcohol use, and many other factors. Some of the scales that I used in my project included the HIV Internalized Stigma Scale, which is a 4-question scale scored from 1 to 5, where higher scores indicate greater negative beliefs about oneself. A couple example questions from this survey include, having HIV makes me feel like I'm a bad person, or having HIV is disgusting to me. I also used the PHQ-9 scale to measure depression, which is scored 0 to 27, where higher scores indicate more severe depression symptoms. Lastly, I used index, which is a care engagement scale, scored from 1 to 5, where higher scores indicate higher levels of patient engagement and satisfaction with their HIV medical care. Some example questions from this survey include, how much does your HIV care provider really understand you as a person? Or, how well do you follow through on HIV care when things in your life get tough? The index was created to measure active care engagement and perceived connection to HIV medical care, with the goal of capturing what care engagement means beyond viral suppression and appointment attendance. It can help identify those who are at risk for disengagement and viral rebound, and can inform targeted interventions to improve retention and care. This measure was validated in a large sample of people living with HIV in the United States with strong reliability and measurement invariance, meaning that this survey was validated in different racial groups to show that the outcome is the same among different groups of people and is thus valid for use in our Latinx population. After analyzing my data in SAS, our population of 297 Latinx people across the CNICS network showed about an average internalized stigma score of 2, indicating generally low levels of internalized stigma in our sample. The average depression score was 5.8, which indicates mild depression symptoms. And lastly, the average care engagement scale was 4.5, which indicated that participants generally had reported feelings of well engagement in their HIV care. You can find these statistics in the red box on the top of the table. After running our mediation analysis in M+, the results showed that HIV stigma was significantly associated with care engagement. Specifically, for every 1 unit increase in internalized HIV stigma, the expected care engagement score decreased by 0.085 points on average. However, we found no evidence that depression mediated the association between that depression mediated the association between HIV stigma and care engagement. So just to reiterate, higher levels of internalized HIV stigma were associated with poor care engagement. However, depression did not mediate the relationship between stigma and engagement and care. Although depression was not a significant mediator in my analysis, it's important to know that previous research has shown that depression has been a mediator between the relationship between internalized stigma and ART adherence. This suggests that the relationship between stigma, depression, and HIV-related outcomes may be more complex and may depend on the specific outcome being studied. Even though my analysis was not significant, after completing a research project, it's important to look toward the future. We need to continue to understand, create, fund, and advocate for interventions that address HIV stigma and mental health, including approaches such as cognitive behavioral therapy, peer support groups, and community conversations. We could also expand this research to data sets that include more diverse demographic groups and include individuals with a wider range of care engagement levels, which may help us better understand this relationship. And lastly, if you or someone you know is struggling with HIV stigma, there are resources available to help you, and I have attached a resource guide at the end of this presentation. It's also important to note the limitations of a study. The first is that our sample only included Latinx participants, which limits the generalizability of our findings to other populations. Second, we found overall high levels of engagement in our sample, which make it difficult to understand the experiences of people who are not engaged in their care. And third, although the association between stigma and care engagement was statistically significant, we found that the magnitude of the association was relatively small. These limitations highlight the importance of continuing to investigate stigma as a barrier to HIV care engagement and work toward identifying other factors that may help explain this relationship. And just as I mentioned previously, there are many groups here in San Francisco that provide support and resources related to HIV care. There's many more options available than shown here on this slide. There's a website you can also check out as well at the SF Health Network HIV Health Services Resource Guide. And that is the end of my presentation. I just wanted to say thank you to my mentor, Dr. Naja Alicia, who is unfortunately on vacation, but if she's watching this, hello. Enjoy your vacation. And then to Dr. John Sauceda and Jonathan Fuchs, to Lauren Dangerfield for putting the whole program together, the National Institute on Drug Abuse for funding this program, and then of course to my Sharpies. And then, yeah, and everyone else who's helped me along the way. And feel free to get my LinkedIn here.
Congratulations and thank you, Califia. So we'll open it up for questions here. While people think, or Jonathan will get started.
Olivia, that was outstanding, thank you. And I think you brought to light the challenges of looking at a mediation analysis. I don't think I've ever heard somebody explain a mediation analysis as eloquently as you just did, so thank you. I think you pointed to a really important challenge with this study. You looked at large academic medical centers across the United States. You saw relatively high levels of engagement and lower levels of depression and internalized stigma. I'm curious what your thoughts are. You talked about next steps, because prior studies have shown this important relationship in mediation of depression with internalized stigma and care engagement. How might you look at that, or what are some other ways you might be able to look at that question with either a different sample or a larger sample? What are your thoughts there?
Yeah, I think it's really important to note where we're getting the data from. And like I mentioned, these are universities that are world-renowned for their research for their medical schools. So people are being trained at the top of their game, which really create a more welcoming environment for patients. So patients could actually look forward to going into these sites because they are so well equipped to handle stigma, to handle discrimination, whereas more rural sites, places that aren't as equipped to handle more complicated like psychological factors like stigma might contribute to someone's internalized stigma. So I think it's important to research more rural areas and places that aren't in such academic areas, because that is skewing the data. Because yeah, we did find that there was like very high levels of engagement in care, which is wonderful, but it is also important to find the people that are not engaged in care, and they might be at sites that are smaller, not in these big cities. So yeah, that's definitely a place for future research.
Natasha.
Hi, really great presentation. I mean, this is like top of the top, like as far as analysis and pushing yourself. So I really enjoyed this presentation. You know, you talked about the facilities being sort of maybe a driver of sort of the outcomes that you saw. And you were working with, I would say, maybe a medium-sized data set. It wasn't small, it wasn't large, it was somewhere in the middle. I guess, you know, what maybe triggered my thought process was maybe the actual patients might be different in these sites. And so I guess if you had to do this over again, would you hypothesize like certain Latina communities might be experiencing stigma and depression, and how you would look at those populations?
Yeah, no, I really thought that almost the data was going to be different. I thought I would see like greater levels of internalized stigma, especially for the Latinx community. Unfortunately, the data set that I was given did not even include other demographic groups, so I didn't have a good comparison of this one is so much worse or better. I was just looking at like previous research that had showed that Latinx communities experience more internalized stigma, but I think if I were to do this again, I would want just more data overall to help myself like understand and compare the different like demographic groups.
Round of applause for Clethia. Thanks so much.
Alrighty, thank you, Califia. I'm gonna move this down. So I would like to invite our next speaker up. Her name is Hanai Elias. She is a first-generation college student from a family of immigrant refugees from El Salvador. She received her public health major with a minor in Latina studies at San Francisco State University. She grew up in Bayview, Hunters Point. Shout out D10. And witnessed and felt lots of healthcare accessibility gaps, which shaped her commitment to healthcare reform and culturally sensitive, community-centered healthcare. Please invite Hanai.
Oh. A bit tall. I think that's good. I can just yell.
Yeah.
Oh. All right. Good morning, everyone. Buenos dias. My name is Hanais, and I had the pleasure to work with Dr. Natasha Lowe-Barron on mapping overdose risk environments to optimize harm reduction outreach among people who inject drugs in Ciudad Juarez, Mexico. So a little bit about me. I am a first-generation Salvadorian American here born and raised in San Francisco. Once again, shout out Bayview District. I had the pleasure from graduating from San Francisco State University with my bachelor's in public health and a minor in Latino studies. And with that, these experiences have shaped me to pursue my master's in public health in community-engaged epidemiology with a focus in community-based participatory research in order to focus on promoting health equity. So I'll briefly introduce you into the people that I'm going to be working with, which are people who inject drugs, or PWID, HIV and overdose, and the frameworks that were used to better understand overdose vulnerability. So about 4.1 million people live globally with HIV, and approximately 5% are people who inject drugs, PWID. This is a key population because HIV can be transmitted through both sexual and injection-related exposures. But HIV isn't the only major health outcome affecting this population. PWID experience interconnected health risks like HIV and overdose, but share drivers like housing instability, criminalization, and stigma, as well as limited harm reduction access. And while HIV surveillance is well established, overdose remains less understood in Mexico. Harm reduction organizations like Programa Compañeros are therefore critical because they provide the trusted, low barrier, and HIV overdose prevention services. And rather than focusing on just the individual behavior, we use the risk environment framework to better understand the conditions that shape vulnerability. So Rhodes 2002 describes the risk environment as the social or physical space where factors interact to increase drug-related harm. And instead of asking, why did this person overdose? This framework asks, what conditions increase their vulnerability? And it can be divided into 4 different sections. First being physical factors that include the spaces around PWID, like housing, neighborhood conditions, and injecting locations, as well as social factors like relationships, community stigma, injection practices, and social support, as well as economic factors like employment, criminalized income sources, and housing affordability, and political factors like drug policy, criminalization, harm reduction funding, and access to prevention and treatment. And with that framework in mind, I'll move us to geographically where this study takes place. Our study takes place in Ciudad Juárez, which is directly across the US-Mexico border from El Paso, Texas. The El Paso-Ciudad Juárez Metroplex is a highly mobile border region with more than 35,000 daily border crossings. Ciudad Juárez has also experienced structural challenges like violence, corruption, and its location along a major drug trafficking corridor. And our community partner, Programa Compañeros, provides HIV overdose prevention services to more than 10,000 people who inject drugs. So our conversations with Compañeros led to our practical question. How common are overdose experiences, and where should outreach be prioritized? Which led me to my question. How overdose risk environments differ between people who inject drugs, who experienced and/or witnessed an overdose, and those who didn't, and where prevention resources should be located to maximize service reach. And in this, we had 3 aims: to describe the study population, compare risk environment factors between overdose and non-overdose groups, and using ArcGIS to identify priority outreach locations. Now I'll briefly walk through our study design and our analytic approach. So we analyzed our cross-sectional data from 149 participants collected from June to September 2023 through a community outreach program called Programa Compañeros. Participants had the opportunity to complete a 90-minute survey, which included a geospatial component where identified locations of witnessed and/or experienced overdoses using Google Maps. For my first aim, we used descriptive statistics, and for my second aim, we conducted a bivariate analysis comparing the overdose and non-overdose groups using the chi-square or Fisher's exact test for categorical variables and a t-test for continuous variables. For my third aim, we used 3 GIS approaches. First, heat maps, which ask where are overdoses concentrated, and the k-means analysis, which overdose locations group together. And a location allocation analysis, or LAA, which asks where should outreach be located to reach the greatest number of people. I'll move into our results. In our sample, which included 149 participants, with the majority identifying as cis men and approximately 12% as cis women, and the majority being single. The median age was 45, and about 2/3 reported having a place to live. More than 80% had less than a high school education, and more than 80% reported no recent incarceration. Income was also varied, about 1/3 reporting 1 income source, and 14% reporting more than 3 income sources. For our bivariate analysis, I want to highlight the statistics in the red box. So we compared 105 participants who experienced or witnessed an overdose with those 44 who did not. I want to focus on the variables that were significant. So first, economic risk. The participants in the overdose group were significantly more likely to report criminalized work and/or sex or transactional sex. We also saw differences in recent substance use, with the overdose group significantly more likely to use crack or cocaine, methamphetamine, and sedative use. Overall, these findings suggest that participants with an overdose experiences were more likely to experience greater economic and substance use vulnerabilities compared to those who did not. Moving on to our next findings, we saw significant differences in related to violence and access to harm reduction. Participants in the overdose group were significantly more likely to report experiences of physical violence, forced sex, and being threatened with a weapon. They were also more likely to report multiple barriers to accessing harm reduction services. Together, these findings show that overdose doesn't exist in isolation. Participants with an overdose experience were more likely to report vulnerability across multiple parts of their risk environment, like economic conditions, substance use, violence, and barriers to services, which helps us to look beyond the individual and instead consider the broader environment surrounding the overdose vulnerability. For my third aim, we used ArcGIS to move from describing the overdose vulnerability to identify where outreach could potentially have the greatest reach. And before we look at the maps, I want to orient you as to where we are in Ciudad Juárez and El Paso, Texas. I've gone ahead and highlighted the border crossing, La X, and Ciudad Juárez International Airport as landmarks. Of 228 total overdose coordinates, 36 represented personal overdose experiences. And these heat maps are useful because they turn the individual location into a visual pattern of density, with the lighter yellow areas representing the greatest concentrations, while the darker representing the lowest concentrations. Even with fewer experienced overdose locations, we can begin to see where the events concentrate geographically. And using that same method, 192 of the 228 coordinates represented witnessed overdoses. So we see the strongest concentrations in northern Juárez, along with smaller concentrations down south. When we combine both groups, of the 149 participants provided 228 overdose coordinates, the key takeaway is that reported overdoses aren't evenly distributed, the greatest concentration lying in northern Juárez, with two smaller ones, concentrations in further down south Juárez. Side by side, both maps show how concentration in northern Juárez might have possible overlaps as well as those down south. These heat maps describe where densities exist, but they don't objectively define the clusters, so we need to look at the underlying points. Each point here represents an individual reported overdose location, and we can visually see groupings, but rather than deciding ourselves where the clusters begin and end, we use data-driven clustering methods. The K-means analysis, which asks where overdose locations group together geographically, informs us through Programa Compañeros, including a minimum of 5 coordinates and 2.5 kilometer distance, which is roughly 30 to 40 minutes on foot. We identified 3 major clusters, the first and the largest, 172, the second with 40, and 9 in the third. We identified 6 outliers, highlighting that geographically isolated overdose locations might be harder to reach when outreach focuses on the greater concentrations with the higher demands. Our LAA asked where the location is needed most, and where should outreach be positioned to maximize coverage. We use geographic centers of clusters as candidate locations and all overdose coordinates as demand locations and a maximum walking distance of 2.5 kilometers. The largest, being in northern Juárez, identified the optimal location that already aligns with existing work by Programa Compañeros, and the 2 further down south showing possible suggestions for more locations. So applying the same analysis, we see smaller clusters identified in the 2 additional potential outreach locations down south. They aren't meant to replace community knowledge. They are data-driven recommendations that can be considered alongside the knowledge and feasibility, safety, and community needs. So I'll bring this together by focusing on 3 main findings. First, that overdose burden was substantial. About 70% of participants had experienced and/or witnessed an overdose. Second, that overdose experience was associated with greater vulnerability across several parts of the risk environment, including criminalized work, polysubstance use, and violence. And third, that geospatial analysis identified 3 priority locations. This study revealed several limitations, that cross-sectional data can't establish causality, and self-reported measures might be affected by recall bias or misclassification. We also saw that participants may have underreported sensitive experiences because of stigma, discrimination, or other concerns. So we worked to minimize this through Programa Compañeros. So I want to bring this together by suggesting the opportunities to expand outreach in northern and southern Juarez to strengthen polysubstance and overdose prevention and address structural vulnerabilities like violence, criminalized work, and barriers to harm reduction. Ultimately, we want these findings to help answer 3 practical questions. Where should we go? What resources should we provide? And what conditions need to change? And with that, I'd like to acknowledge a couple people that made this project possible. Primeramente, gracias a Programa Compañeros y los participantes, estos datos son mucho más que números, representan los testimonios y experiencias de los participantes. Gracias por la confianza y por el trabajo que hacen por sus comunidades. Y también muchísimas gracias a la doctora Natasha por su paciencia, mentoría y por ayudarme a imaginarme en los espacios donde nunca pensé que podría estar. Me voy de Sharp gracias a usted, muy inspirada y emocionada por lo que viene. Thank you, Lauren, Dr. Fuchs, and Dr. Saucedo for your support and encouragement, and to my fellow Sharpies for all the love and support throughout this program. If you would like to connect, you can scan the QR code.
Outstanding job, Hanais. So we have time for questions for Hanais. I'll get started while people think. Hanais, I know it's a new setting for you in terms of traveling down to the Texas-Mexico border, but can you talk about sort of some of the challenges of reaching, or just how large that difference is, and any discussions you have around the capacity to sort of expand those services to Southern Juarez?
Well, first, thank you for your question. So through dialogue with Programa Compañeros, I guess to answer your question on more of how do we get our resources down to South Juarez, it's important to acknowledge that through conversation, there isn't a lot of capacity through Programa Compañeros to be able to provide resources all over. So through our 6 outliers, it got difficult because that wasn't necessarily it wasn't involved in the other clusters. So by placing the vans through Programa Compañeros down in these 2 locations, unfortunately, those outliers do get excluded. However, when we think about resource outreach, we also want to consider realistically, how is this word being spread? We rely on word of mouth. We rely on individuals telling the people that they might inject with or the communities that they're in that these resources exist, which is why we had our restrictions of 2.5 kilometers, which is a 30 to 40-minute walking distance, because we can't expect individuals to have the resources. And Gabby did an amazing job of talking about transportation and how that affects people's ability to receive care and to access care. And so using those same sentiments, we have to be considerate of what exactly is going on in our environment, specifically down south in Ciudad Juarez, that might prevent an individual from receiving care from the vans.
Thank you. Other questions? Anais.
I have a question about the harm reduction that's provided, since it doesn't look like it's primarily opiates like it is here. So what kind of harm reduction supplies does the program provide?
So we did a lot of fentanyl testing, syringes, as well as pamphlets on education. I don't know if Dr. said you could. And the Loxone. Oh, I'm forgetting.
It is primarily, yeah, it's naloxone, fentanyl test strips,
HIV testing.
yeah, harm reduction kits,
Yeah.
clean needles, etc. there. But it is primarily heroin. It's 100%. Yeah. All right. Well, round of applause for Hanais. Thank you.
All right, sorry. I would love to invite our next speaker up. So Joy Kenner is a public health practice major at the University of Maryland College Park with a special interest in health equity research, community outreach, and sexual reproductive health. Before coming to UMD, Joy earned her associate's degree in health sciences from Prince George Community Colleges through an early college program, graduating with both her degree and high school diploma in 2023. She'll also be starting her master's program at the same college, University of Maryland, where she will be pursuing a master's in public health and health equity. I would love to invite Joy up.
Good morning, everyone.
Good morning.
I want to thank my fellow scholars for their amazing presentations, and I want to give an extra special thanks to my colleague Hanais for setting the stage for my presentation. My name is Joy Kenner, and I've been working with Dr. Natasha Ludwig-Barron and Dr. John Seseda on my project titled Investigating the Relationship Between Past Year Violence Exposure and HIV-Related Injection and Sexual Risk Behavior Among People Who Inject Drugs in Ciudad Juarez, Mexico. To provide a little bit about myself, I am a first-generation college student born and raised in Prince George's County, Maryland, and I recently graduated from the University of Maryland College Park with a bachelor's in public health practice, and I will be returning to Maryland in the fall to complete my MPH in health equity. For my professional interests, I am interested in advancing public health through community health, HIV prevention, and implementation science research, and my future plans are to pursue a PhD and conduct research full-time. For a bit of background on my project, local estimates suggest that there are more than 10,000 people who inject drugs in Ciudad Juarez, and approximately 10% of those are HIV positive. 70% of those are also hepatitis C positive, and both rates far exceed the general population. For context, Ciudad Juarez is burdened by heavy drug market violence, policing, and opioid traffic, and there is also a disproportionate HIV burden among women at 20% in comparison to 5% in their male counterparts. So why look at violence specifically? As we know, Ciudad Juarez is shaped by heavy drug market violence and population displacement. And as a result, physical, sexual, and psychological violence are common, and this violence occurs across multiple settings, including intimate relationships, policing, homelessness, incarceration, and drug use environments. Given this, we have an understanding that violence is a structural driver of HIV vulnerability, and exposure to violence shapes where, when, and how people inject, which limits one's ability to use safe injection practices and access harm reduction services. Though violence is established as a structural driver, research does not currently have an understanding of how violence exposure influences injection and sexual risk behaviors in this population. And the gap that my project hopes to address is how violence exposure may be uniquely important given the unique context, setting, and history and high frequency of injection drug use and access to heroin in this population. So as my colleague Hanais presented, this study is also informed by the risk environment framework, which spans 4 factors: physical, social, economic, and political. For my study, the social and political factors are particularly relevant since violence and drug use would theoretically be shaped by these macro and micro levels, including drug policy, criminalization, violence, and gender inequity. And this framework is what motivated looking at violence as a predictor of downstream risk behavior. With that context, here's the question I set out to answer. Among a sample of adult people who inject drugs in Ciudad Juarez, is past year violence exposure positively associated with HIV-related injection and sexual risk behavior? And my hypothesis were that higher levels of violence exposure will be associated with greater odds of reporting HIV-related injection and sexual risk behavior. This analysis also uses data from Proyecto Vida, and it is a cross-sectional survey with 149 people who inject drugs conducted from June to September of 2023. And eligibility for the study included being at least 18 years of age, having recently injected within the past month, and being willing to test for HIV, hepatitis C, and fentanyl use. Data came from an interviewer-administered risk environment questionnaire, which captured violence, stigma, housing, and risk behaviors. And to further operationalize these terms, I define violence exposures as physical threat, weapon threat, and forced sex within the past year, HIV-related injection behavior as injecting with someone else's used syringe within the past year, and HIV-related sexual behaviors as condomless sex at last encounter, and giving or receiving money or goods for sex within the past year. And condomless sex is especially important to flag here, since PrEP use is low in this population, and without that additional protection, condomless sex carries an additional HIV risk. A quick look at who's in my sample. The average age among participants was 43.7, and it was an overwhelmingly male sample at 86%. 33% reported being unstably housed, and 75% had a 9th grade education or less. 98% of participants were born in Mexico, and the median years lived in Ciudad Juarez was 33 years. Before getting to my results, here is how I approached my analyses. First, I used an exposure outcome structure, looking at physical assault, weapon threat, and forced sex, our 3 violence exposures, against 4 HIV-related risk behaviors. And I used a 2-part strategy, first using a composite score to establish an overall association, followed by an exploratory behavior-specific model for outcome specificity. First, I used my composite score as a 0 to 3 count of the endorsed behaviors, and each behavior was scored as a 0 or 1 and sum across the 3 outcomes. For my exploratory model, I tested against all 4 outcomes using a Fisher's exact and age and sex-adjusted logistic regression. Looking at how common these exposures were, we found that 47% of participants reported experiencing a physical assault, followed by 26% who experienced weapon threat, and 11% who experienced forced sex. For HIV-related risk behaviors, syringe sharing and condomless sex were the most prevalent at 70% and 69%, followed by receiving money for sex and gave money for sex at 30% and 19%. Looking at the results, starting with the composite score, we find that 17% of participants reported experiencing 0 violence exposures, whereas 43% of participants reported experiencing 1. 24% of participants experienced 2 violence exposures, and 16% experienced all 3. In the adjusted models, we see that each exposure was associated with a higher rate of the composite score, and the rate ratio compares the rate of the outcome between the 2 groups. Physical assault had a rate ratio of 1.42, meaning that there was a 42% higher odds of those who experienced a physical assault in their higher composite scores. So we expected to see a direct association between our composite violence exposure and our risk behavior variables. And here, as an exploratory exercise, I looked at which individual items went into each composite. Our 3 violence exposures being physical, weapon threat, and forced sex, followed by our 4 outcomes, syringe sharing, condomless sex, received money for sex, and gave money for sex, for a total of 12 comparisons. I first ran a bivariate Fisher's exact test, followed by my adjusted logistic regression for both age and sex. So to orient you to these figures, we see that in the unadjusted logistic regression, on the x-axis are our 4 HIV-related risk behaviors, and on our y-axis are our 3 violence exposures. We see that syringe sharing is statistically significantly associated with physical assault, and that received money for sex is also statistically significantly associated with forced sex, weapon threat, and physical assault. And we see similar outcomes in our adjusted logistic regression. We see that a physical assault has an odds ratio of 2.4, which tells us how many times more likely the behavior is for people with that exposure, meaning that those who were exposed to physical assault had a 2.4 times the likelihood of syringe sharing behavior. Given this analysis, I have two primary findings. In our composite pattern, we see that each additional violence exposure endorsed was associated with a 31 to 47% higher adjusted rates of HIV-related risk behavior. And on the right, we see our exposure-specific pattern, which tells us that different types of violence exposures were positively associated with different HIV-related risk behaviors. Physical assault associated with syringe sharing, physical assault associated with receiving money for sex, and weapon threat and forced sex associated with receiving money for sex. So in terms of what this means for our implications, findings support routinely screening for violence exposure within harm reduction and HIV prevention services for people who inject drugs, particularly around transactional sex. Addressing violence exposure also requires integrating harm reduction, HIV prevention, and public safety and policing reform efforts. And finally, interventions in Ciudad Juarez must account for the cross-border drug market dynamics, migration, and policing practices specific to this binational corridor. Future research should prioritize longitudinal binational studies to establish temporality, evaluate structural interventions such as policing reform and trauma-informed harm reduction for the effects on risk behavior, and examine how the evolving drug markets and housing instability can shape violence and risk behavior in this population. Three limitations to consider was that this was a cross-sectional design, so violence exposure and risk behavior were measured in the same past-year window, and temporal order cannot be established. In addition, we did have some small cell sizes across comparisons, as only 16 participants reported forced sex, and that the 12 bivariate tests were not corrected for its multiple comparison. And finally, the behaviors were self-reported in a single-site convenience sample of people who inject drugs in Ciudad Juarez, which may limit the generalizability to other populations. I want to give a thank you to my two mentors, Dr. Natasha Ludwig-Barron and Dr. John Ciceda, for helping me build my project from start to finish, as well as a special thanks to the Proyecto Vida team and participants. I also want to thank the SHARP program, including Lauren Dangerfield and Dr. Jonathan Fuchs, for providing me with this opportunity, as well as my fellow Sharpies for making this an increasingly fulfilling opportunity, and our funders for making this opportunity possible. Thank you all. I'm happy to take any questions.
Joy, that was an outstanding presentation. Thank you. We have time for questions, please.
Thank you for that presentation. That was awesome. I had a question, especially in the beginning, as you were talking about the conceptualization. The risk environments that you highlighted were the social and the political, but given that one of your findings was how associations with money for sex was such kind of a consistent finding across the types of violence, I was wondering if you thought there were any economic implications or in terms of programmatic and structural interventions on that side.
Absolutely. The risk environment framework was used as a basis for the entirety of the study and project, but the economic factors and the economic subsection of the risk environment framework was particularly important, especially looking at giving money for sex. And we found that there was a specific relationship between the women in our sample and their reporting of giving money for sex, which may explain some additional economic barriers or other economic barriers within the sample that can be looked at in relation to violence or any other exposure.
Any other questions? Last question before we close, before we go to our break. All right, please join me in congratulating Joy. Thank you.
Alrighty, so we are about to embark on a break. But before we hop to that break, I wanted to invite Amy Lee up to just tell you a little bit about a smaller project that they worked on during the summer, and just share a little bit about that, and then feel free to check it out while y'all are on your break.
Thank you. So in about a minute, you will see projected onto the screen over there a photo voice exhibit that the students put together. So for those of you who don't know, photo voice is a participatory action research methodology, which is generally used to encourage participants to document, reflect on, and communicate their lived experiences. And the purpose really is to drive social change. So the students throughout the summer documented their experiences, and in the exhibit you'll see that the story that they're telling of their growth and transformation as emerging scholars. But ultimately, I think this is a love letter. And it is a love letter to the program, but to each other and to all the relationships that they formed this summer. So I really encourage you to please take a look and get to know our scholars a little bit better. Thank you.
Good morning, everyone. Hi, Mom, Dad, and my best friends from home watching on the live stream. Thank you, Dr. Fuchs, for the beautiful introduction. If you couldn't tell, I'm really excited to be here. My name is Catalina Doe, and today I'll be presenting my program evaluation of San Francisco City Clinic's HIV RNA monitoring program, completed under the mentorship of Dr. Oliver Bacon, who is the City Clinic Director. Before I begin, I want to briefly introduce myself. I'm a recent graduate of the University of San Francisco with a bachelor's degree in public health. I am a proud Vietnamese American born and raised here in the Bay Area, and the immigrant underserved families who raised me inspired my commitment to making healthcare more accessible and close to home. I hope to pursue an MD MPH and become an internal medicine physician serving in my beautiful home that I call the Bay. I want to begin with why this program is important. As we know, viral suppression is essential to individual and public health. People who maintain an undetectable viral load experience better health outcomes and do not sexually transmit HIV, otherwise known as U equals U, or undetectable equals untransmittable, and this reflects the principle that treatment is prevention. We often think of the traditional HIV care cascade as linear, shown on the slide above, but engagement is often cyclical. People may disengage and re-enter care because of changes in housing, insurance, medication access, or other circumstances. This is known as churn. During that churn, a missed HIV visit can also mean a missed opportunity to detect a rising viral load. This is where a sexual health visit comes in, where it provides another low barrier opportunity to identify unexpected viremia. This program operates at San Francisco City Clinic, which provides confidential HIV and STI testing, treatment, and prevention, to name a few. The HIV RNA monitoring program is funded by the CDC, and the clinic can serve as an important safety net when someone continues to seek sexual health care after missing routine HIV care. Here's how the program works. First, staff identify a patient living with HIV who reports being in care and taking ART. During the sexual health visit, the patient may be offered a random viral load test. This test is called random because it occurs outside a scheduled HIV care appointment, and the test is then sent to the public health laboratory. People already known to be out of care or off ART are eligible for existing LINKS navigation services. This program focuses on a different group, however. People thought to be in care and on ART whose detectable results suggest their care may be less stable than it appeared. When a viral load above 20 is identified, nurses attempt to disclose the result through outreach, assess barriers, and connect the patient with an appropriate support action. The goal of this program is not to just simply detect viremia, but to identify unexpected viremia and reconnect patients with HIV care and support. That same goal shaped my program evaluation of the program's patient follow-up process and implementation. My quantitative research question asks, what proportion of patients progress through each stage of the follow-up cascade, where do losses occur, and how do patterns of follow-up vary by viral load group and over time? My qualitative question explored how do clinicians and nurses experience implementation of the HIV RNA monitoring program, and what factors influence follow-up for patients with detectable viral loads. For this evaluation, I used a mixed methods approach. The quantitative data set covered March 2022 through June 2025. Jaime Morales, a research assistant at City Clinic, completed the EPIC chart abstraction and transferred the data into an Excel sheet. I was then sent that Excel sheet and analyzed encounter level, patient level follow-up, documented barriers, and patterns over time. For the qualitative portion, Dr. Bacon invited eligible staff, and from there I conducted 7 semi-structured interviews with 5 clinicians and 2 nurses about workflow, feasibility, patient response, and recommendations, followed by a rapid thematic analysis. I now want to walk through the quantitative data set from left to right. On the left, the program had a 49.5% acceptance rate. Because testing is optional, about half of eligible patients accepted, while slightly more than half declined. Without a test result, declined encounters could not move into nurse follow-up. Among those tested, 588 results were group 1, meaning undetectable. This is a positive clinical outcome, but group 1, along with declined encounters, were excluded from my program evaluation because nurses only conducted outreach after a detectable result. Therefore, this evaluation focuses on group 2 and groups 3. Group 2 includes 54 encounters with low-level detectable viral loads between 20 and 109 copies per milliliter. These results were expected to trigger nurse follow-up. Group 3 included 46 encounters with highly detectable viral loads of 200 copies or higher. These results may indicate a larger gap in treatment or care and generally require more urgent follow-up. Together, groups 2 and group 3 made up 100 detectable encounters involving 88 unique patients, meaning a few patients appeared more than once. 71% of those patients met all documented eligibility criteria. And I just want to reiterate, being eligible means living with HIV, reporting that you're in care, and reporting that you're taking ART. For the remaining 29 encounters, at least one criterion was unmet or unclear in the chart. However, I retained all 100 detectable encounters because the evaluation examined what happened after a detectable result was identified. At the encounter level, all 100 began with a detectable viral load, but only 54 had a documented outreach attempt. The largest loss occurred immediately after detection, with 46% having no outreach documented. Among all 100 encounters, 22 had an attempted contact, but the patient was not reached. 32 resulted in disclosure after outreach, and 5 more were disclosed through other documented means. This brought the total to 37 disclosures overall, or 37%. Outreach shows an attempt. Disclosure confirms the patient received the result. I then looked at unique patients, so repeat visits will not overstate follow-up. Of the 88 patients, 50, or 56.8%, received documented outreach. However, only 36, or 40.9%, had documented completed disclosure. At the patient level, disclosure was the clearest gap. Attempting contact is not the same as ensuring that someone receives their result. Additionally, Group 3 triggered more action, but not more completed disclosure. Outreach occurred in 60.9% of Group 3 encounters, compared with 48.1% of Group 2 encounters. Any documented action was also higher for Group 3, with 80.4% compared with 50%. Even so, disclosure was similar between the groups. A more urgent result prompted greater staff activity, but that activity did not always lead to successful contact. The previous slide showed that Group 3 prompted more staff attention, raising the question of what barriers did these patients face. Among Group 3 patients reached by nurses, medication access was the most commonly documented barrier to virologic control. This included insurance interruptions and difficulty obtaining ART. A highly detectable result was not always simply about whether someone chose to take medication, but sometimes the medication was difficult to obtain. Follow-up, therefore, needs to include practical help with insurance and ART access and not just disclosure. I did also want to highlight that follow-up did improve with the program over time. From 2022 through 2024, documented outreach increased by 44.8 percentage points, and disclosure improved as well. But still, disclosure remained lower than outreach. Staff were making more attempts, but reaching patients and closing the loop remained difficult. My interviews help explain this gap. Nurses describe outreach and documentation as major follow-up gaps. One nurse with 4 years of experience in the program said, "It would be nice to have someone able to go out into the field and connect with the patient where they are at." Another nurse with 2 years of experience in the program said, "The most difficult thing is trying to reach the patient." This matched the quantitative findings of 23 narrative notes containing language related to contact difficulty. Unreliable contact information and housing instability could prevent outreach attempt from becoming a completed disclosure. Clinicians focused on the information and feedback needed to act. One clinician with 4 years in the program said, "It would be helpful to hear what it has uncovered and what the outcomes were, referring to the viral load test." Another clinician with 3 years of experience explained, "It's really important to ensure that we have correct information because now we have this result and we can't act on it properly." With only 40.9%, or 36 out of 88 patients having documented complete disclosure, verifying contact information is not simply an administrative task. It is part of the intervention. From the interviews, 3 themes emerged across both groups in the order shown here. First, testing was easy to initiate, but harder to close. Second, reliable information needs structure and clear responsibility. Third, visible outcomes reinforce the program's value because staff want to know whether testing led to disclosure or re-engagement. Overall, testing was feasible. The greater challenge was ensuring that the result led somewhere. Taken together, testing identifies risk, but follow-up determines its impact. At the encounter level, 46%, or 46 encounters, had no documented outreach or disclosure. At the patient level, only 40.9%, or 36 patients, had documented complete disclosure. And although 80.4% of Group 3 encounters had some action documented, disclosure remained limited. Across all 7 interviews, 5 clinicians and 2 nurses, reaching patients and closing the loop emerged as the main challenges. These findings suggest 3 main points. First, random viral load testing is feasible and can uncover unexpected viremia among people who appear to be in care and taking ART. Second, medication access is especially important for patients with highly detectable viral loads. Third, the program's value depends on reliable follow-up and visible disclosure. I did also want to mention that this data also has its limitations. Documentation fields represent overlapping workflow events, repeat encounters are not independent, and 7 interviews cannot represent every staff interview. Some follow-up may have also occurred without being documented, but overall, feasible implementation does not automatically translate into completed follow-up. Based on these findings, I recommend 5 changes shown from left to right. First, standardized documentation for outreach, disclosure, barriers, actions, and disposition. Second, verify phone numbers and portal access at check-in before the patient leaves. Third, clearly assign responsibility for result review, outreach, escalation, and closure. Fourth, prioritize medication access and insurance navigation. And finally, close the loop by sharing program outcomes and eligibility reminders with staff. Together, these changes can create a stronger handoff from a detectable result to meaningful support. This program gives us a second chance to identify people who may be quietly slipping out of care, but detection is only the beginning. And because I'm a sentimental person, I do want to take a moment to thank a few people. I want to thank NIDA for investing in our success, the SHARP team, Lauren, Dr. Salceda, Dr. Fuchs, for giving me this opportunity this summer and believing in me. The clinicians and nurses at City Clinic for participating in my qualitative interviews, Jaime Morales for helping out with the quantitative data set, Dr. Oliver Bacon for being a wonderful mentor. If you didn't know, I'm his first SHARP mentee, and I truly hope I'm not his last, because he was such an amazing mentor, and he's the definition of I want to be him when I grow up. And lastly, I want to thank my fellow SHARP scholars. I'm incredibly grateful to have gotten to spend the summer with 5 of the most inspiring individuals, and I know that in 20 years we will be returning. We will be returning not as scholars, but as mentors, inspiring the next generation of public health professionals, just as our mentors have inspired us. And lastly, I want to say to everyone in the room, even though this chapter is ending, this is not goodbye. It's simply a see you on LinkedIn. So. So feel free to add me on LinkedIn. I'd love to stay connected. And with that said, that is my presentation, and I'm happy to answer any questions. Thank you.
Catalina, that was wonderful. Thank you so much. We have time for questions. Oh, please.
Okay, well, thank you so much for your presentation, Catalina, and thank you for the kind words. I love you.
Could you explain a little bit more about the differences between what you meant by completed disclosure, outreach, and I think it was an action?
Yeah, thank you so much for your question, Hanai. So I define outreach as an attempt to contact the patient. Completed disclosure means the patient received the results, and then an action documented was a broader term I used to describe both a outreach and a completed disclosure, but also in case a provider referred, or a provider City Clinic referred the patient to another primary care provider, referral, or another documented response. So those are my clear definitions of what each mean. Thank you.
Great. Catalina, just a clarifying question. So there's a lot of work in your analysis. You showed that attempts at disclosure, outreach, and then disclosure. Were there attempts to also try to get in touch with the primary care providers, those who are providing HIV care to individuals who you identified were virally suppressed?
Mm-hmm. Yeah, that's a really great question, and the answer is yes, there were attempts to reach a primary care provider, and the clinicians at City Clinic do have consent to reach out to primary care providers of the patients that visit them.
Great, thank you.
Catalina, great presentation. On the low versus high viral load, and you showed the difference in the percentage of taking action in terms of the follow-up. Was that did you have discussions, or what's your thought on, is that a resource constraint in the terms of we don't have enough staff to go after all of the patients who have a detectable viral load, so we're going to start with those with the highest? Or was it that providers and the staff saw a high viral load and immediately focused on that group, and sort of they could have gone to the low detectable group, but were focused on the high detectable group?
Yeah, that's a really great question. I would not say it's not limited staff, because staff at City Clinic are amazing and they're really great at giving the patient their results. But I would say, me and Dr. Bacon have talked about this, but a reason could be that group 2 encounters could potentially be blips. And until Dr. Bacon gets that data in a month, we'll be able to better tell. But I would also say, yes, it is because once the staff see that the patient has a greater viral load, they're more likely to put in more effort to attempt to reach the patient.
Can I comment on that? It's a great question, and Adeline is absolutely right. There was no distinction made about the urgency of follow-up based on group 2 low viral load versus group 3 high viral load. Both were to receive outreach. So we don't actually know why outreach and action was so much higher for group 3. And I think, in the next iteration of this, I think that's a question for city clinic staff. My hunch is that our nurses are very astute regarding the meaning of a viral load. And my hunch, which could be wrong, is that they were more motivated by a high viral load than a low, less than 200 viral load, but that is just a theory. And we'll know, we're going to do EHARS matching of all of our visits with prior and subsequent viral load trajectories, so we'll be able to know who was blipping and who wasn't blipping.
Great, thank you. Thank you so much, Catalina.
I would love to introduce our last but not least speaker. Chris So is a biology student at the University of British Columbia, born and raised in San Francisco. Maybe not D10, but he's still from here, so it's all good. Growing up in a community with fractured dialects of health inspired his goal to become a physician scientist capable of translating complex laboratory findings into lived experience for the community. Please welcome up Christopher So.
Good afternoon, everyone. Thank you all for being here. Thank you, Lauren, for the great introduction, and thank you to my fellow Sharp Scholars for their great presentations. I definitely learned a lot, and I hope you guys all did as well. My name is Chris, and today I'm going to be presenting my term project titled Opioid Use Intentionality and Mortality Among People Who Have Experienced a Non-Fatal Opioid Overdose in San Francisco. So a little bit about me. As Lauren mentioned, I was born and raised here in San Francisco. I'm a third year at the University of British Columbia studying biology, and prior to this program, I did agricultural research with the Government of Canada, and I've also done volunteer research work with the BC Children's Hospital, as well as UBC's IDEA Lab. I'm an aspiring physician, and I'm also very interested in continuing research regarding substance use and addiction. To start, a study from the New England Journal of Medicine found that the number of opioid overdose deaths in the US increased tenfold from 1999 to 2022, with fentanyl being a leading cause of opioid overdose deaths in 2021. Another study found that 1 in 5 people who had a non-fatal opioid overdose experienced a subsequent opioid overdose within 12 months or a year, with the fatalities of these subsequent overdoses increasing as fentanyl becomes more prevalent within the drug market. In a more localized study of 488 individuals who experienced a non-fatal opioid overdose in San Francisco, 42% of them had not intended to use opioids and had instead intended to use other substances such as methamphetamine. This unintentional use of opioids can happen through the use of shared equipment as well as misidentifying stimulants. Fentanyl, for example, looks exactly like methamphetamine. An unsuspecting individual could then take methamphetamine at the club or in the park and experience an opioid overdose because their methamphetamine may have been laced with opioids. On the other hand, people who do intend to use opioids may do so with other stimulants, as it is believed that the other stimulants would reverse the sedative effects of opioids. This, however, is very dangerous and also heightens the risk of a fatal opioid overdose. But there's not enough data on the long-term follow-up after a non-fatal opioid overdose in those who did not intend to use opioids compared to those who did intend to use opioids. Which leads to my research question, which reads, is there an association between opioid use intentionality and subsequent overdose death among those living in San Francisco who have experienced a non-fatal opioid overdose? My study has 3 main research objectives, the first being to describe the demographics and characteristics of those who have experienced a non-fatal opioid overdose by intentionality. We also aim to compare the time between a non-fatal opioid overdose to subsequent all-cause mortality and subsequent fatal opioid overdose, and categorize that by intentionality. And finally, we aim to compare the ratio of death events by intentionality groups. For this project, I pulled data from the Home Overdose Prevention and Engagement Program, which is a post-overdose response team for housed individuals. People were referred to the HOPE program through EMS, various housing groups, as well as street overdose response teams, and were then connected to overdose recovery programs as well as support groups. We collected data from the HOPE program from June 1st, 2022 to May 15, 2025. We also looked at death records from the California State Vital Statistics records through December 11, 2025 for a total of 1,380 individuals. To start this project, we first performed a bivariate analysis for demographics and characteristics based on intentionality, reporting frequencies and percentages for categorical variables, as well as the interquartile range and median for continuous variables. To test for significance, we used a Pearson chi-square test as well as a Wilcoxon rank sum test for categorical and continuous variables respectively. We also conducted a survival analysis using a Kaplan-Meier curve to assess the time from non-fatal opioid overdose to all-cause mortality, as well as time from non-fatal opioid overdose to subsequent fatal opioid overdose. Finally, we used a Poisson regression model to compare the incidence rate of death between both intentionality groups. Jumping into my results, in a table 1 of demographics and characteristics among people who have experienced a non-fatal opioid overdose in San Francisco, we first saw that people who did intend to use opioids during their index non-fatal opioid overdose were often younger than those who did not intend to use opioids. We also found that among race and ethnicity, people who intended to use opioids during their index non-fatal opioid overdose were white, whereas the plurality of those who did not intend to use opioids were Black or African American. To continue, we also found that those who intended to use opioids during their index non-fatal opioid overdose event had intended to use fentanyl, whereas those who did not intend to use opioids had instead intended to use substances such as methamphetamine and cocaine. We also conducted a survival analysis on time from index non-fatal opioid overdose to subsequent all-cause mortality using a Kaplan-Meier curve. Here, the y-axis shows survival probability, where 1 represents a 100% cohort survival and 0.75 represents a 75% cohort survival. This data is shown over time in years, and we can first see that the survivorship curves for those who did intend to use opioids versus those who did not intend to use opioids is very similar, and we also saw a steep drop in both curves immediately after their index non-fatal opioid overdose event. In a similar analysis where the event was subsequent fatal opioid overdose, a similar trend is seen as in when the event was all-cause mortality, where again, we see that the intentionality curves are similar and there is a steep drop in survivorship after an index non-fatal opioid overdose event. Lastly, we use a Poisson regression to compare the incidence rate of death between those who did intend to use opioids versus those who did not intend to use opioids during their index non-fatal opioid overdose event. But we did not find a difference. This is shown by a confidence interval that crosses 1 and a p-value greater than 0.05. We then conducted the same analysis, but adjusted for covariates such as age, race, and housing type, but again did not find a difference in the incidence of death between those who meant to use opioids and those who did not mean to use opioids during their index non-fatal opioid overdose event. To conclude, under a long-term study of people who experience a non-fatal opioid overdose by intentionality, we found that the risk of death, as well as the time to death, in this is the same after a non-fatal opioid overdose, both in people who intended to use opioids and those who did not intend to use opioids. We also found in our table 1 that the plurality of those who did not mean to use opioids were Black or African Americans. They were often older individuals, and they had often instead intended to use methamphetamine or cocaine. Our study had 2 main study limitations. The first being that because a majority of our data was gathered through interview, recall bias as well as perceived stigma may have affected reported intention, as well as substance use, as people may fear repercussion from reporting an intention to use opioids or an intention of using certain substances. It's also important to note that all participants in this data set were housed, which leaves out a significant proportion of people at risk of unintentional opioid use or opioid overdoses, that being people who are unhoused. Looking forward, based on what we learned, we should increase prevention initiatives to reach people who do not intend to use opioids, since they may not see themselves as at risk of unintentional opioid use or opioid overdose. The steep drop in survivorship after a non-fatal opioid overdose in both intentionality groups also suggests the need for better rapid response linkage to care, as well as an improvement in post-overdose recovery programs. Finally, I'd like to make a couple acknowledgements. First, to my mentors, Grace and Dr. Coffin, for coaching me and supporting me through my entire project. I'd like to acknowledge Nora for giving me feedback on my statistical analysis, as well as helping me translate these statistics into my project. I'd like to thank Dr. Bazazi as well as Dr. Lowe for answering all my questions regarding the HOPE dataset. I'd like to thank Dr. Fuchs, Dr. Saceda, as well as Lauren for giving me this opportunity to be a part of the SHARP program in such a great research atmosphere, as well as for running the SHARP program behind the scenes and supporting me and my fellow SHARP scholars. I'd finally like to thank my fellow SHARP scholars for being such an inspiration and such a great support group these past 10 weeks. And finally, I'd like to thank the NIH for funding SHARP and my ability to do this work. Thank you all for listening to my presentation, and I'd like to open the floor to questions.
Fantastic, Christopher. Thank you. Excellent presentation. We have time for questions. Please.
Thanks, Chris. Excellent job. Do you have any thoughts on that age difference? It was like 43, 51. And any thoughts around why that was? And also, if you have any insights on that comparing to other metropolitan areas, is that on average an older group, that even if you had that difference of 7 years? And then second part, how housed were the sample here? I mean, was it stable housing or sort of intermittent sort of housing?
Yeah, great question. So I think your first question was on the differences between age and intentionality. To be completely frank, I'm not really sure why there is such a significant difference. If I were to hypothesize, I would say that maybe people who are younger are more informed of the drug market than people who are older. And I think your second question was, what did I mean by housed individuals? And so in this project, we categorize housed individuals as people who are housed and people who are living in supportive housing. So people who are living in supportive housing were people who lived in SROs, and this is a very important differentiation because people who live in SROs are often at a higher risk of an opioid overdose because they're often taking or they're often consuming opioids in a closed environment alone, which means less access to that rapid response linkage to care, which is quite bad because, as I said earlier, there's a steep drop in survivorship after, like a couple months after the non-fatal opioid overdose. So yeah, if that answers your question.
Please.
Really great presentation. Again, I think the question that I have is, here at least we have a lot of access to fentanyl test strips, and so I'm always wondering how that's affecting the drug market, how that's affecting people's use. And so I wondered if you knew if any of these participants had access to fentanyl test strips and maybe, that affected your intentionality versus, unintended use.
Yeah, great question. So I think your question was asking how our city's access to fentanyl test strips influenced my study. I would say, I think, oh, sorry.
Do you want to talk?
Yeah. Dr. Coffin can save me.
We haven't chatted about that. Unfortunately, the studies with fentanyl test strips, even a trial of fentanyl test strips, have not shown any benefit. Part of the reason is because the test strips themselves have certain limitations. They false positive for methamphetamine. They false positive with Benadryl, which is in a lot of cocaine. So they're not really as useful as we'd like them to be. And in general, people on the street just don't really use them. The people who use stimulants don't see themselves at risk of an opioid overdose, so they don't want to test it. The people who use opioids are in San Francisco, 95% of them are intending to use fentanyl anyway.
Great. Chris, thank you so much for your presentation.
Yeah,
thank you
thanks
to
for
all
this
of our
opportunity.
scholars for their incredible presentation. And
Awesome. So congratulations to our 2026 scholars. We just finished our presentations. One more round of applause. Great. So next, I would love to announce and invite up our special guest, Director Dan Tsai.
Thank you. So I ran over here and I'm very sweaty, so I can't keep the tie on anymore around that. I'm very sad I didn't get to listen to any of the presentations. I did get, where are the Sharp Scholars? Can you raise your hand? Oh, they're all, I've met a few of you at the Pride Parade. You were all in the front carrying the banner. It's pretty awesome on that. Thank you. That was exciting to meet you all. And I actually did not know what the Sharp Scholar program was until I heard about this and read about it. So that's excellent and awesome. And I'm very glad you were able to be here with us. I'm glad Jonathan and the CLI team and others, you can have the, oh, thank you. I spent a lot of time running between meetings and trying to trying to not be too late. I'm really pleased that we are able to support this with funding support from, what's the funding source? NIH. Excellent. This team is quite scrappy at being able to bring things like that to fruition. And I think what's really exciting also is part of the mission of public health is to make sure that we can do pretty amazing research, which I think this department does probably more so than any other department, DPH, in the country. And that's a pretty cool thing, and I think to be proud of here in San Francisco. And to have folks with a whole variety of experiences not only do research, but think about it in a very applied context here on the ground in San Francisco or in other relevant places, and to translate research into not just theoretical policy, but what do we do on the ground to, is it Christopher? I heard the very end, Christopher, yes, Christopher, on overdoses in various settings, or some of the other things where I had a small blurb that I got a sense of what your various projects were. But that's really exciting and cool, and not just cool, but I think what it takes to have public health be not just cutting edge, but impacting the real lives of people and what we're trying to do here in San Francisco and informing actual, actions and stuff. So thank you. And my main hope and pitch is, I don't know you all. I don't know what your plans are on things. I assume you're in this program because you care about this sort of work. Public health, communities that are marginalized and underserved, how to tackle intractable, seemingly intractable, difficult problems with data, with creativity, with compassion, with lived experience, with people's voices, with data, all of that. And so my hope is, as you all figure out your careers, unless we've recruited them all already, that you stay in, where there are opportunities here at the DPH here in San Francisco, but in public health, public serving, safety net serving, or work of this sort. Because I'm sure you all will have many, many opportunities to do many different things. And it's exciting that you are participating and spent 10 weeks of your summers here with us. And hopefully that launches a really fulfilling, exciting, meaningful, public service-oriented careers for you all as well. So I want to say thank you to you all. And is it possible for me just to get the presentations that they went through so I can flip through them?
They've all been recorded, so we'll be able to send you the link.
On that, or in the synopsis of some of those things, just to see what you all have done. And thank you to the broader PhD team and our researchers and CLI and everyone for really making this sort of thing happen. It's pretty unique. So I think that's mainly what I wanted to thank you.
And it's really great partnership too with UCSF.
With UCSF, thank you, UCSF. On that, UCSF, DPH, yes, yes. And I was just doing grand rounds at UCSF yesterday, intersecting with both our UCSF DPH side and some of the clinical teams on the other side. I assume there's all sorts of intersections beyond just that piece and with the School of Medicine and other things, but it's really amazing that we have that partnership with UCSF and we can work in this way. So thank you, and I hope, did you enjoy your time? Good. Thank you to the team. So that's, anything else?
Thank you.
Appreciate you all. Thank you, and stick with us. Thank you.
All right, so we are getting ready to present our certificates. So if I could have our PRs come on up. We'll let you. Okay, cool. Alrighty, in no particular order, I would love to present our scholars. So the first person I would like to present our certificate for is Gabriella. Our next student I would like to present to is Joy Kenner. All right, our next student is going to be Hanai Elias. Our next scholar is going to be Christopher So. All right. Our next scholar is Califia Oldham. And last but certainly not least, Catalina Doe. Alrighty. Before we jump in, I would love to talk, Jonathan, to share a little bit about our 2026 Mentor of the Year.
Great. Thank you so much, Lauren. Congratulations again to our scholars. Give them a round of applause, please. And I just harkening back to just a little while ago when Dr. Phillip introduced us and launched our symposium, talked about the power of mentors. And as we know, I think the Odyssey is getting quite a bit of play right now. So I don't know if you know the history of the term mentor, but it's when Odysseus, before he launched on his major journey, his son Telemachus was put into the care and support of mentor. And so that is the very term that we use and use today, and it really defines what our mentors do to be able to support the careers and the trajectories of their mentees. And I can say with confidence that all of our mentors have contributed so much to the success of our scholars and hopefully setting them on the course for future research careers, both here in the DPH at UCSF and of institutions around the country. So thank you. A round of applause to all of our mentors for their incredible work. Many of you are here in the room. Could you please stand up if you are a mentor? Please stand up. I know we have several of our mentors here, please. Yes, thank you. Great. And every year, for the past several years, we've been identifying a particular mentor that we wanted to acknowledge for their incredible contributions. All of our mentors have contributed, and particularly this year, we wanted to take a moment and acknowledge Dr. Ludwig-Baron, Natasha Ludwig-Baron. So congratulations. We want to just say a word about her. She finished her MPH at Emory University and her PhD in epidemiology at the University of Washington and completed her postdoctoral training right here at UCSF. She's been a mentor for the past 4 years, lecturing as well for our scholars, has also worked with our sister program, the CFAR Scholars program over at UCSF. You have been incredibly dedicated this year, served as primary mentor for Hanais and for Joy, and we really just are absolutely thrilled to have you as part of the program to contribute your expertise and your love and devotion to our scholars. So please join me in congratulating Dr. Natasha Ludwig-Baron. Come on up. A few more thank yous. I want to just take a moment. This program would not be possible without the talent, the dedication, and the support of Lauren Dangerfield. So please join me in congratulating yeah, this program would not be possible without you, I have to say. These flowers are for you on behalf of all of us, and we know that you love matcha, love Japan, and so that was an inspiration. Right, exactly. So enjoy that. But Lauren, through everything, your organizational prowess, to be able to, the devil's in the details, and you basically, single-handedly are able to bring it all together, culminating in this incredible experience that we've had together. So I just want to thank you for all of the effort, the support you provide, all of the mentors, clearly the support you provide for all of our scholars. And we're just incredibly indebted to you for all of your contributions. So thank you, Lauren.
I'm a back of the house kind of person, so I'm a thank you. But I would like to say thank you all for coming. We really, really appreciate you taking the time to hear from our scholars and learn a lot about them. We do have a QR code on the left side if you would like to scan and just tell us about your experience, but otherwise we also have lunch outside, so feel free to grab a box lunch, but feel free to continue to network with the scholars. They're only here till tomorrow, hint, hint. But we're very excited to have you all, and congratulations to you all. Thank you.